Okay, we are start this session. Welcome to the COACT Chip Symposium. Let's begin with the first session. The title of this session is Lithotripsy, New Solution for Highly Calcified Lesions. We invited two famous interventional cardiologists in America and Hong Kong. Thank you, Dr. Andre Pop, for joining us as an online speaker. As you know, lithotripsy balloons is an innovative device in the field of cardiovascular intervention. Unfortunately, it has not entered Korea. So we hope through this session to experts who are familiar with the use of lithotripsy balloon can share their experience, and thus we can learn a lot from this session about lithotripsy balloon. The first speaker is Dr. Andre Pop. He is interventional cardiologist of Alexian Brothers Medical Center, Illinois. He is currently director of cardiac cath lab and head of structural heart program. I personally intimately know Andre Pop, and he has many experience with the lithotripsy balloon. I asked him to share his knowledge and experience in this topic. So his topic is the role of lithotripsy in chip lesions, in current situation and future direction in the United States. Please, Dr. Andre.
Thank you, Dr. Chang. Thank you to the organizers for inviting me to this prestigious meeting. I will share my screen now. And
recording in progress.
Okay. Intravascular lithotripsy is a technique that we use a lot and that has been proven to be very useful in the treatment of heavily calcified lesions. As you know, coronary calcium can be very challenging. When you try to deal with heavily calcified lesions, there's a high risk of dissection, a high risk of arterial rupture. We all know that we have challenges with stent delivery. And we also know that full stent extension can be prevented by the excessive calcium. As you can see from this intravascular ultrasound image, a lot of times these calcific nodules prevent stent deployment, and that is associated with decreased durability and increased risk of stent thrombosis. As we also know, severe coronary calcification dramatically increases the risk of complications after coronary intervention. As you can see, patients who had severe calcium had a much higher mortality in this series than people who did not have severe coronary calcium. So what tools do we have currently? We have balloons. The problem with balloons is that the main impact of the force of the balloon is away from the calcium. So the pressure is actually displaced away from the calcified lesion that we're trying to treat. And so there is always a risk of arterial rupture when we use high pressure or very high pressure balloons. Rotablator, which I use a lot of, is a great device. The problem is it requires a very small 0.09 inch wire, which is very unsupportive. And it also, if not used properly, can result in distal embolization, no reflow. If there is severe angulation, there is a risk of perforation of the artery as well. So coronary intravascular lithotripsy, this is the technology. It has been used for many years in the treatment of kidney stones. It is basically a balloon that has in it a miniaturized array of emitters that basically are designed to break calcium in the lesion. The device, as you can see, is made out of a console, which is quite small and quite mobile, a balloon that is connected to the console, which is advanced intracoronary. This is how it works. Basically, it emits these shock waves which break the calcium. One important or very important point I would say is that the calcium is broken inside the vessel wall and does not embolize. Basically, the calcium remains in the vessel wall beyond the endothelium, underneath the endothelium, and as opposed to rotational or orbital atherectomy, the calcium does not leave the vessel wall and there is no risk of embolization. Also, because there's very low pressure that's being used, we do these procedures at 2 to 4 atmospheres. I personally have never had a arterial rupture with a shockwave balloon, neither in the coronaries nor in the periphery. So this video shows you basically
Dr. Park, I cannot hear you.
So basically, there was a video showing how the intravascular lithotripsy works. The mechanism of action is basically fracturing the calcium inside the vessel wall. And this demonstrates in a benchtop model how the calcium breaks. However, if you touch the balloon, actually, there's no danger to you because soft tissues are not affected. These are OCT images which show how the fractures happen in the calcium. The data from the literature is pretty good. Quite a number of studies have shown the device to be very safe and to prevent dissections and perforations. These are data that have been published in JACC CVI, showing again the safety of this technique. Regardless of the calcium morphology, whether it's concentric, eccentric, or nodular, the technique has been shown to be very safe. And one advantage it has over rotablator is that, or orbital atherectomy, that affects the calcium, whether it's superficial or deep inside the wall, whereas rotablator and orbital atherectomy only touch the more superficial calcium. Another source of great satisfaction for us is that it works very well in women. We know women have smaller arteries and have higher complications after coronary intervention. But basically, in a multi-site registry, it's been shown that shockwave is effective in women as well as in men with lower complication rates than other technologies. Based on this, actually, there is a consensus document that recommends the use of shockwave in women as a way to prevent complications. So some real world examples. These are situations where we use this technology in heavily angulated vessels. The ostial circumflex is something that I use it a lot in because the angulation can preclude safe orbital or rotational atherectomy because of the angle from the left main. Tortuous ostial vessels are other good examples. These are a few examples from our center. This is a patient where you can see on the left there was severe angulation in the circumflex, and we treated it effectively without having any problems with shockwave. This is a case that one of my colleagues did, a chronic total occlusion, where after externalizing the wire and switching from a transseptal approach to an antegrade approach, shockwave was utilized, resulting in a very good result. This is a case that I did before Shockwave was available in STEMI. In STEMI, I rarely do atherectomy. And in this case, in a relatively young man, I did not appreciate a very focal ring of calcium. And as you can see, after stenting, the stent was not expanded. Patient had a CT in 2016, and you can see the very focal ring of calcium with stent under expansion. And when the patient restenosed, we confirmed these findings. We went in with Shockwave, and we had much better expansion, basically able to expand the calcium behind the stent without any difficulty. These are other examples where we use lithotripsy. This is a case where the abdominal aorta was severely stenotic, and we had to do a transcatheter aortic valve replacement. But in some situations, this has been used also to facilitate the placement of Impella or other large bore intra-aortic devices. So in an 89-year-old woman with a IVUS determined minimal abdominal aortic diameter of 2.8 millimeters, we used two large Shockwave balloons, 7-millimeter Shockwave balloons. We were able to expand the abdominal aorta, and we were able to place an endograft, which later allowed us to do TAVR without any difficulty. Also used a lot in periphery, obviously not the topic of the symposium, but this is a case where we used rotablator followed by IVL in the common femoral artery in a patient who had other contraindications, other territories where it is used in areas where you cannot really stent. So in the popliteal artery, I use it a lot. So that's all I had. Thank you very much. Appreciate it.
I am Young-gun. I'm from Korea. I work in Jeonnam National University Hospital. Actually, we will have a discussion at the end of session. So I'd like to introduce in the second speaker is Michael Kang In Rui in Hong Kong. He works in Queen Elizabeth Hospital. Dr. Rui, can you hear me?
Yes, I can hear you well. Can you hear me?
Yeah, nice to meet you again.
Good to see you.
Even though it's the UNTACT, the symposium. The Michael Rui, actually, I don't have his CV in the book, but I realized that he received in the interventional cardiologist training at Brigham Women's Hospital.
Yes.
Actually, I'm not sure, 1919 or 2000. Then he is the leader of the interventional cardiologist in Hong Kong. Actually, he works in the Queen Elizabeth Hospital. He has many experience in the complex PCI. Today, he will talk about the real-world application of lithotripsy in coronary calcium, Hong Kong's experience. Dr. Rui, please.
Oh, thank you for your very kind introduction, and thank you for the kind invitation for me to talk about this a newer toy for us to tackle calcium in the cath lab, intravascular lithotripsy. We know that the more severe the calcium, the thicker the calcium, the more extensive it is, then the outcome will be worse. No matter what kind of endpoints you are looking at, even death, cardiac death, and the MACE, all these will actually increases with the amount of calcium. We have to use some sort of imaging to assess calcium before we tackle coronary artery interventional procedures. So IVUS and OCT are the two basic imaging modalities that we have. They have advantages with each other, and both of them are actually very good in assessing coronary calcium. We have IVUS-derived calcium score. So if you see this circumferential calcium, very extensive calcium nodule in a small coronary artery, then the score will be high, and then actually people tend to use more of the atherectomy devices in addition to just balloon and stent. What we have been using is mostly the OCT-derived calcium score. So we look at the arc of the calcium, the thickness of the calcium, as well as the length of the calcium. so as to give them the coronary arteries score. When we have a high score, then probably we will go for atherectomy procedures. So we have quite a number of atherectomy devices available in our lab, and IVL is probably the newest to us. This actually has been explained previously that you actually use electrical energy to cause a sort of a high-speed sonic pressure wave, so that you will actually have a very, very high pressure up to 40-50 atmospheres to try to impact on the calcium or along the vessel wall, so that it will crack the calcium. So the use of it is very simple. It's just like your ordinary balloon. You just choose the correct size. Usually we choose 1-to-1 size, and then inflate it to a 4 atmosphere. And when you inflate to 4 atmosphere, usually you will see this indentation here. But when you turn on the lithotripsy, then you can see that this disappearance of the indentation because of the cracking of the calcium, so that the compliance of the vessel would be a lot easier, a lot of lower, so that actually the balloon can expand much better. This is what we usually see in the lab when we use OCT, so that you can see this very, very thick calcium. But after cracking with the IVL balloon, you see these cracks here, so that the compliance of the vessel will be actually much better for us to use a further balloon, or it actually can go in with the stent directly. What you can see in the real arterial model is that you really see a crack along the vessel wall over the calcium area, so that the calcium is actually really cracked and fractured. We have the honor to use the first IVL balloon in Asia back in 2019. But after that, actually, I would say that the growth of the IVL balloon used in Hong Kong has been exponential. Up to now, we have used, throughout Hong Kong, we have used more than 2,500 IVL balloons in the coronaries and more than 30 in the peripherals. So we have been using this for quite a number of indications, as you can see here. Usually we use it for concentric calcium, but sometimes eccentric calciums, osteal lesions. When you want to protect a significant side branch with another guide wire, then probably IVL balloon is the way to go. We also use it in STEMI patients, in-stent with stenosis, or a combination use, which I will show you later on. So there are some technical considerations before we use this balloon. We have to know that it is a little bulkier balloon, so it's not as trackable as our ordinary semi-compliant balloon. And it would require a reasonable lumen for it to get through. So when you see a very calcified, very severely narrowed coronary artery, probably we have to use combination atherectomy devices. Go first with a rotablator, open up a track so that we can actually pass the IVL balloon. It is a 6 French compatible, and it can actually pass through guide extension catheters. We usually use 1-to-1 balloon vessel ratio size, and it will be inflated to 4 atmospheres and then deliver the shock for 10 pulses, and then blow it up to 6 atmospheres before deflate, and then go to another lesion. So altogether, one catheter can deliver 8 cycles of 10 pulses each. So altogether 80 pulses. So you have to use your 80 pulses wisely along the coronary artery. So when we go to another artery, we usually use a new IVL balloon, because once this balloon is opened, it's actually very difficult to track down another vessel. We usually would go from distal to proximal, so that you can actually pull out the balloon as you inflate at different places. You might see some artifacts, just like the pacing spikes on the ECG monitor, what we call the IVL-induced pacing spike. And the patient might experience a mild chest pain, but it's all very mild and usually very tolerable for the patient. We have no doubt when we have to use a combination therapy, because we think calcium, when it is very severe, we have to tackle it well. So sometimes we will combine rotablator and orbital atherectomy with the shockwave balloon. Complications, as we mentioned, that they are very rare. Very rarely we will see a balloon rupture or even dissection of the vessel, but it's all mild and easily handled by interventional procedures. It is actually very safe to use. It can also be used in eccentric lesions. Just bear in mind that when you use in eccentric lesions, since the emitter is actually a little further away from the lesion, and it has no, the usual waveform will actually be bounced back by the calcium, so that they can actually go to and forth in the vessel. But for eccentric lesions, because the energy will not be bounced back to the opposite wall, so that we might require a little higher energy or a little more pulses to actually crack the eccentric calcium. But it can be done. So this is a combined study. There are 4 studies altogether, the CAP 1 to 4, with the use of IVL balloon involving more than 600 patients in Europe, in the US, and the CAP 4 is in Japan. So it all point out to a very significant diameter stenosis reduction with the use of IVL balloon and then the stenting. You can see very, very satisfactory luminal diameter after the IVL balloon and then stenting, and very, very low rate of complications. All the complications are actually lower than our ordinary coronary intervention, or I would say very, very comparable. All the hard clinical endpoints. So we can actually also use this in eccentric lesions, as I mentioned. If you look at this analysis of the CAT 1 and 2 studies, you can see that the catheter use or the pulses used are not really very much different, but they can achieve similar luminal diameter or residual stenosis at the end of the procedure. So it can be used in eccentric lesions. Yes, it has been used in in-stent restenosis when the stent is not really expanded adequately because of the calcium outside, or even sometimes neo-intimal proliferation with calcification. That would be the perfect patients for us to use the IVL balloon. It has been used in ACS AMI, as mentioned. We use this when we see calcium, when we do primary PCI as well. So this is our algorithm to tackle calcium. So we use this balloon if the calcification is severe, as assessed by the OCT images. If we can cross, then we would go for IVL balloon directly. If we cannot cross, we would start with rotablation or orbital atherectomy, and then consider adding on IVL balloon before further stenting procedure. So I just show you a couple of cases. They are the more difficult cases that we have to use combination therapy. This is a LAD CTO, big LAD CTO, as you can see here. So we actually start off with a very poor ejection fraction. So we start actually off with placing an impeller for support of this high-risk PCI, cross the lesion, and then exchange for rotofloppy guide wire. And then we decided for upfront rotational atherectomy with 1.5 burr, because I don't think any balloon will cross this very calcified tight stenosis here. So after the burr, you can see that we actually performed OCT for this vessel after rotational atherectomy. You can see that actually we have gained some lumen in the vessel, but the calcium is still very, very thick. Nothing has been done to this thick calcium. So if we place a stent right now, it will actually surely end up with underexpanded stent. So what we have done is that we use 2 balloons, a 2.5 and a 3.0 shockwave balloon, IVL balloon, to further modify the lesions there. And then you can see from the OCT images again that the calcium now is actually really being cracked here. A lot of deep fracture, fissuring, so that the compliance will be better. and then we can actually go for stenting of this vessel and then end up in this very, very nicely expanded stent with good apposition. And this was another case with porcelain aorta. You can see that the left side was heavily calcified, diffuse disease. That was a stage procedure that we have done later on. But for the right, you can see a big vessel, but with, again, calcified coronary anatomy. So what we have decided to do for this case is, because of the OCT images showing very, very thick calcium, 1.8 mm thick calcium. So we decided to go for orbital atherectomy, low speed, and then followed by high speed. And then this is the OCT images after orbital atherectomy. You see nothing happened to this calcium, and then we use shockwave, 2 shockwave balloon, and then stenting with 2 stents, and give this a very nice result, I would say. Very, very satisfactory result. Yes, we mentioned the osteo circumflex lesions. Because of this acute turn, it's hard to use other atherectomy devices. But actually, I just want to show you that this balloon actually can negotiate this curve and allow us to see this curve, allow us to actually do some calcium modification in the very proximal part, osteo part of the circumflex. We have also used this to enable us for the insertion of impeller in very calcified vessel, or as has been shown, when we have to do a TAVI procedure, we use a peripheral shockwave balloon, try to modify the calcium before we put in a big sheath, 14 French E sheath, and then going in with S3 device without much difficulty. So this is a summary of how we would choose the different kinds of atherectomy devices. I would say IVL balloon is actually more versatile. It actually allows its use in most of the calcified lesions, especially in bifurcation osteo lesions. So in conclusion, calcium is probably still one of the worst enemies of interventional procedures. We need to modify this calcium and then guide by imaging so that we can do a very effective and safe stenting procedure at the end. And IVL is very safe to use. We have very low threshold for combination atherectomy with the rotablator and orbital atherectomy. Thank you for your attention. I'm happy to take any questions.
Thank you. Thank you very much for your wonderful presentation. Actually, intravascular lithotripsy is not available in Korea, so probably we have many questions from the basic to fundamental. So we have the panelists in the Kim Chan-jun, who works in the Ujeongbu St. Mary's Hospital, and the Park Sang-min in the Nowon-Ulji Hospital. So in the many audience. So please make some comment or questions.
Maybe my question goes either to Dr. Lee or Dr. Pop. As I understand, lithotripsy is based on the balloon-based procedure. So if the balloon is not delivered, as I understand, from the Dr. Lee's presentation, the additional rota ablation is necessary. But in case, like in the very severe calcification from the os of the artery, I think the rotablation and the subsequent lithotripsy is quite a very difficult situation. So maybe either of the presenters, I'd like to ask you if the balloon, the lithotripsy device is not easily delivered, what is the solution to this calcified lesion? And my second question is that, as I know, the lithotripsy is not favorable in some long diffuse calcified lesion. And in this case, what is an approach to this long diffuse and calcified lesion? Thank you.
So what I would say is the balloon is certainly slightly higher profile than a regular high pressure balloon, but it's not undeliverable either. So using body wires or using a guide extension, generally we're able to deliver the balloon to most lesions. As Dr. Lee explained, if you can't deliver the balloon even under these circumstances, a very undersized rotablation or orbital atherectomy can deliver the balloon, after which the shockwave can be used. Another technique that has been used is basically inching forward the shockwave balloon, delivering a few shocks and then advancing the balloon further. I don't know if Dr. Lee has any other thoughts.
Oh, thank you, Dr. Pop. We have no hesitation to use rotablator at all for this sort of uncrossed lesions. But sometimes, if the cause is a concern, or if the patient's condition would not allow rotational atherectomy, sometimes we will start with a very small balloon, a 1.5 or 2.0 balloon, just to open up a track so that a subsequent IVL balloon will actually cross easier. But if even a very small balloon will not cross, then probably the only solution will be the rotational atherectomy. And for the second question, diffuse lesion, we use quite a lot of IVL balloon in diffuse lesions. Although you have only 80 pulses to deliver, but that's good enough to actually create some dissection, cracking along the vessel, even for diffuse lesions. Of course, if you use rotational atherectomy or orbital atherectomy, you can actually modify the whole vessel. So all the three devices would be used by us for diffusely calcified lesions.
Thank you. I'm Dr. Park working at LG University in Seoul. I have a question to the both professor. Dr. Park shows the only the OCT imaging for the lithotripsy, and Dr. Lee shows the both the IVUS and OCT imaging for the same procedure. Actually, this IV lithotripsy is not available in Korea. Okay. All new thing for us. What is the cornerstone pros using the intravascular imaging, such as IVUS or OCT? Which device you prefer in the procedure?
So in my case, I would say that I'm a very heavy user of intravascular ultrasound. I think the images I showed are just demonstration images, so basically showing you the mechanism of action. And that's where OCT is really nice because it has the highest resolution. However, clinically, I think intravascular ultrasound works very nice because clinically, we don't really care to see the little fractures that happen in the calcium. We care to see the nature of the vessel and then how well the stent is expanded after we've placed the stent or after we've done angioplasty. So clinically, I prefer intravascular ultrasound, although for demonstration purposes, I think IVL is very nice. OCT is very nice.
The same here, we use actually more IVUS than OCT, mainly because of the cost, and then actually you don't have to give contrast with intravascular ultrasound, but you have to know the different criteria for the calcium score. The only drawback with the IVUS is that you cannot see the thickness of the calcium. Sometimes you think the calcium is just superficial calcium, and then you probably would get away without even atherectomy devices. Then you might be fooled by that very thick calcium. But if the IVUS show a circumferential more than 270 degrees calcium, long in a small vessel, if you look at the score, IVUS score, actually that deserves atherectomy already. So I would say both imaging modalities would be good as long as you use it. You have to use this imaging to assess the calcium and then look at the result of the stenting procedure. That's the main aim of our interventional procedures nowadays for calcified lesions.
The other thing I was wanting to say is that if you manage to deliver an intravascular ultrasound catheter, you should have no trouble delivering IVL.
That's right.
In my humble opinion, I think the OCT can easily detect the crack of the calcified plaque. That's right.
Yes, it's more easier seen than the IVUS. Yes, you're right.
Okay, thank you. I have another question to Dr. Pop. I'm really impressed with your great lecture. I have a wondering question. You showed the better outcome of the calcified plaque for women in the intravascular lithotripsy. I'm really interested in the sex difference in the CAD. What do you think about the? Can you explain the mechanism of the or reason why the IV lithotripsy is more advantageous for the woman?
Well, I think the reason is that women tend to have smaller arteries, and when the arteries are small and very heavily calcified, your only options are either atherectomy or very high pressure balloon inflation. And I think sometimes even after atherectomy, you have to have high pressure balloon inflation. Because with IVL, you only go to 4 atmospheres. I really haven't seen situations where we've ruptured the artery. And so for me, that's one of the things that gives me the highest level of comfort is the fact that I don't have to go to high pressure. If I don't use IVL, I will always go to 18, 20, even more atmospheres. But with IVL, you find that the calcium is just fractured. And so it makes you very comfortable to put a balloon, put it at 4 atmospheres, and after several cycles, you see that the balloon is just fully expanded without risking rupture of the artery. So I think that that's where the great benefit comes, is not having to go to high pressure to get full expansion.
Okay, yeah, that's a good point. I got to hand it to you. Thank you.
Okay, so I'm Young-gun. So any of you can make an answer. So I think it's when I think about in the calcified region, maybe thickness of calcium burden, I think is very important. When I think about the very superficial calcified region, I think we don't need in the intravascular lithotripsy because maybe we can just touch with some non-compliant balloon or cutting balloon, or I think it's the low tabulator is sufficient to make breaking the calcified region. However, if we think about very thickness, the calcified region, maybe we need in the intravascular lithotripsy. So, is there some criteria for the thickness of the calcium if we think about in the OCT or IVUS analysis for the calcium burden? So, do you have any data about what is some criteria, or it doesn't matter?
Well, I would say thickness is really the main player here in calcified lesions because, as I mentioned, with IVUS it's difficult to tell the thickness, but with OCT you can actually look at the thickness, measure the thickness. The thicker the calcium, the less compliant will be the vessel, so that it would be very difficult for a stent inside that particular segment to expand. So you look at Kiko's paper on OCT calcium score. Actually, if the calcium is very thick, that together with of course circumferential calcium and then the length of the calcium, if the score is high, more than 3-4, then the stent expansion will be much less than after atherectomy. Then the future clinical events would be a lot higher with those lesions. So for thick calcium, I think if the vessel is very tight, I would try to modify the vessel first with other atherectomy devices, so that you can see from my previous rotator images that you can make a lumen, or even with orbital atherectomy, you can make a lumen, but you cannot crack the calcium for thick calcium. So you really need IVL balloon to finish the job by cracking the calcium, the deep calcium, so that the vessel can expand during stenting procedures.
Well, I totally agree, and I think the other point is that if you've tried already, you know, you've done orbital or rotational atherectomy, or even if you haven't tried any of those, and you put a balloon and you take it, let's say, to 14 atmospheres, and you see that you have a big waste in the balloon, then the question becomes, you know, am I going to take this balloon to 20 or 30 atmospheres and risk a rupture, risk a dissection, risk a balloon rupture, or do I go with IVL? And in the case that I showed where I had a relatively young person with a ST elevation myocardial infarction, where again, I'm reluctant to use rotational or orbital atherectomy, the calcium wasn't so much thick, but it was concentric. It was essentially a ring of calcium that did not allow the balloon to expand. So if I had had in 2016 access to this technology, I would have used it, but back then we didn't have it. So I think once you recognize that the balloon is not expanding fully, that's where you have to go back and to say, do I use rotational, do I use orbital atherectomy, or do I use IVL from the get-go?
Thank you.
I'd like to have another question, please. As widely known, autoablation is not indicated or even contraindicated in some cases, like on vessel with high thrombus burden, or the cabbage graft vessel, or very small vessel. So is there could be any contraindication to the IVL in the coronary intervention? The procedure of either like in the kind of vessel or the clinical presentation?
I think you're muted, Dr. Lee.
I'm sorry, yeah. Sorry. For me, I don't think I have any restrictions on the use of IVL. So I would use it in any sort of calcified lesions with a huge side branch. You can protect with a guide wire. Even after pre-dilatation, you have dissection. You can still use IVL balloon, but you cannot use especially orbital atherectomy. Sometimes you can still use water bladder, though at a risk. So I don't think there are any lesions that I would not use IVL balloon unless I cannot cross the lesion, because it's a little bulkier balloon. So for very tight calcified stenosis, it might not cross. I think that might be the only limitation. And sometimes the IVL balloon might not work as well in calcified nodule, in the setting of calcified nodules, because it's hard to crack that calcified nodule. So sometimes other atherectomy devices might be better for this sort of scenario.
I agree, and I would say that the only limitation would be situations where you cannot deliver the balloon. In those situations, a lot of times using something like a Corsair or using body wires is a good technique, or a guide extension. I think that Dr. Lee's point is very good about bifurcation lesions. In that situation in particular, I think that using IVL is great, because you can protect the lesion, which you cannot do with rotational or orbital atherectomy. I think the point about degenerated grafts is also good. In those situations, we use this with no concerns. I think the other technique that Dr. Lee has shown is in situations where you're concerned about severely depressed LV systolic function. Let's say you're doing left main, unprotected left main, and you're concerned about prolonged balloon inflation with IVL. I think in that situation, using some sort of support like Impella is very, very reasonable.
I thank you. I have another question and comments. I'm really interested in the part of the ISR. As you know, we came across the repeated ISR. We have no way to the further strategy. In this aspect, this device is very promising, I think. So, but what do you think about you guys do, both doctor shows that introduce the ISR case. This means that this device can make a crack the metal stand strut. Just out of my curiosity.
So I don't think that it affects metal because it's a different mechanism. The shocks do not affect metal. I think for ISR, if the ISR is really fibrosis that happens after stent placement, this is not going to make a difference. However, where it is very valuable is if somebody, and we see this all the time with cases that come from outside hospitals, somebody did not pay attention, did not fully expand the lesion before deploying the stent, then they put a stent in and the stent is not fully expanded, like in my situation with the acute MI case, then coming back and doing shockwave, which allows the fracture of the calcium behind the stent, is valuable. The device is not approved for this indication in the United States, but we use it all the time because it works very well behind the stent.
Thank you for your active discussion. I'd like to ask you the final question to both of you. And although I don't have any experience in IVL, I can guess IVL is very effective in diffuse calcified lesions, but I'm not sure the effect of the IVL on eccentric calcified nodule. So do you have any experience in these lesions?
Yes, we've used it sometimes in eccentric lesions. As you can see from the further analysis from the CAT1 and CAT2 trial, even for eccentric calcium, actually, it can be effectively modified to have a very similar lumen gain with the concentric calcium. The only thing that you need to pay attention is that you might need to stay at the eccentric calcium a little longer than concentric calcium. You might deliver more energy to actually crack the eccentric calcium. But other than that, I think it works equally well as the concentric calcium. The only thing I cannot be sure is the calcified nodule. So if it is only one nodule, then it might be very difficult to crack that nodule. But for eccentric calcium, concentric calcium, I think it works for both types of calcium.
Yeah, I agree, and I think that in areas where the calcium is very eccentric, but there's only one area affected, or when you have a calcified nodule, I will spend all the 80 pulses on one area, and that makes a lot of times a difference. If it doesn't fully crack the calcium, then you sometimes do still need higher pressure inflation, or you need some sort of atherectomy or debulking. But you know, it's not panacea, but it's certainly a very valuable tool in our armamentarium.
Yeah, this session was a great opportunity to learn about DW3C. I would like to thank you, two speakers, Dr. Lee and Dr. Park, and panelists who joined in this discussion. I hope we'll meet both of you in person and learn a lot about the DW3C and other interventions. Thank you.
Yeah. Thank you. And see you soon. Bye-bye.
Bye.